Very warm congratulations to you, all of my beloved doctor colleagues from different countries,
Thank you, sir.
to our OSCE session right now. It's the first day of introduction. We will talk today some introductory talks, some preparation tips and others. And we will practice a little, very introductory things today. You know most of the thing, and we have provided more or less some text materials to you before. And with this concept, we will practice a little as introductory issues. The case presentation will be directly case presentation from the second class. So this is myself, Dr. M. Osman Ghani. I'm working as associate professor in capital city of my country in the medical college here in the Department of Medicine. And as the institute chief, I like to add that we are busy with this preparatory program for the Royal Colleges, especially from last 7 years around. And some of the colleagues now becoming even the mentor of some other studies as well. So this is our pleasure. Anyway, this is the name of our institute. Uh, we don't like to tell that we are very big institute, but in our limited facilities, we try our best to help our colleagues throughout the world. So the learning materials, actually, it is the intellectual property of our institute. So this is a little moral alert for you. You can distribute, disseminate, no doubt, but it needs a consent from the authority. This is a gentle reminder for you as the discussion. You are having all the rights to criticize of our discussion, of our introduction, anything. And in the first class, as introductory class, we are going there. That today we will try to discuss you the OSCE strategy, tips and tricks, many things you see. And you know, in the meantime, many of you have some orientation in previous days. So even then, from our side, what we are thinking about, we'd like to share our understanding with you. And regarding the class participation, you know, you have attended many where that whenever you have question, you will raise your hand. Then we'll give you the signal so that you can talk, so that we should not collide each other during our talk. So as we are very not too much big one, in small group discussion, I think we know also how to manage the decency and the smooth running of the classes as well. So we expect your cooperation as well. When I talk in the meantime, you can raise your hand. And when I give a pause, then you can ask me the question. Don't think that at the end of half an hour, 1 hour, you will raise the question. You can note in a paper also what you need to discuss in my according to the my talk. So coming to next one, you know, this exam, the objective structured clinical examination, 14 station with some rest issue also in between. And the 10 minute station, you know, that 1 minute before entering the station. And the more interesting thing is that no active role of the examiner is there. In the Royal College, usually select the cases in the South Asian countries. This is the in context of the country. That means the South Asian problem, health problem, they like to highlight there. So we have to be oriented, especially those who are from the Middle East countries, the Arab peoples. It is very important for you that the health issues and the problem is not as like your country in the Gulf areas. So you have to be more serious about orientation of the health problem of South Asian countries. So most of the time, these are mostly the infective diseases, mainly the respirology and the gastroenterology, especially in the pediatric case. So anyway, we will have this attention to the case selection for you in the practice session also. So if you are thinking also how the exam is conducted, this is only the snapshot shown to you. This is the room, this is the doctor, this is the patient, surrogate, and this is the waiting area in between the station. You are having the water for the drinking, 10 minutes time like a station. And this is the arrangement of inside the chamber, examiner here, this is the doctor, this is the surrogate, So eye-to-eye contact maintained by the examiner to the surrogate, but doctor actually away from the patient's eye. So it is psychologically comfortable not to be in the eye to the examiner because you are talking to the patient, you will keep your eye-to-eye contact with the patient. And over the table, you see that many materials, drinking water, there is a tissue box, there may be some devices also. Whenever you find the devices are there in the station, usually you are to instruct the patient how to use it. This is an indirect clue for you. So always keep your eyes over the devices. If any chart or other pictures are there, you have to show to the patient. So this is very important. How what materials are there in the over the table, right? So this is the mark sheet. You have seen possibly before also many aware that how they are giving the mark in these headlines. Mainly of four headlines you have seen here. You can see here, and the grade awarded by these excellent, competent, unsatisfactory, and the poor. So we don't need to be busy with this gradation, but we have to be excellent in our practice. This is our target, not that we will be competent. So in our classes, we'll try our best to instruct you, to guide you with our experience gathered before. Just to start about the OSCE, the some it is very usual that throughout the world the examination of different types having extraordinary fascination. So, in my sense as a mentor and as a fellow, as a member of Royal College of General Practitioners, I observed that in the OSCE examination, these points are very important in a case presentation or the case evaluation. The red flags, hidden agenda, eyes, safety rating, ethical issue, health promotion, and the responsibility of the patient for their health. What we are teaching them also, this is also important. And eyes, idea, concern, and expectation. So we should not miss in our practice this point. But for understanding of the consultation, the Royal College proposed 23 principles to improve your consulting skill. These are the big list here. Uh, you have this skill more or less, I know, but from these 23 points, many of you know though, but I don't like to discuss this thing here. If you need possibly, I don't know, did I give you PDF or not? One of the article written by myself. I can provide to you also in a group that how to improve consulting skill. And in this article, I tried my best to discuss 23 points there. Then what does it mean? So even when you are looking at the screen, if you want to ask me also from the 23 point, you can raise your hand also or have a note also. In course of time, I can discuss in the break time. There are 23 points. 23 points. So we can discuss also in the practice session. No worry. And the infection prevention is a big issue nowadays in the exam. Modified approach we are now taking. Personal hygiene is important. Nail, hair, beard, and mustache also, especially in the male doctor, to be guarded by this head. For the female, or better to use the head cap to control your hairs. Hair should not be suspended, and the clothing will be bare below elbow policy. So better to use a T-shirt or T-type blouse also. A female doctor can wear, or even the better to avoid the white coats. White coats give a different identity to the patient. For that, white coats are not encouraged. You can use mild perfume, not very arrogant, pungent, or very heavy. So that hair should be covered, especially for the female. And the wrist watch is rather discouraged. So to utilize the watch in the time, I can show you the watch how to be used, different watch. Better. Then hand decontamination. We are more or now practicing this sanitizer. We are now bound and compelled for the COVID situation. Sanitize before entering the chamber. And when you sneeze, sneeze in the elbow, not in the hand. So these are some simple tricks for you for the infection prevention control issue. Uh, if we show you the watch, possibly have you seen the watch or not here? Let us see. This is the watch. So if it is the watch, so you can buy if you have, may not be available in every country. You can keep in the pocket whenever you need to see the time. You take from the pocket and put it down again. Or if you don't have this thing, also, if actually it is designed for the suspending from the belt. If you're the female doctor, you may not have the pant and belt, so you have to keep it in the pocket. But the male doctor can use it by clipping there in the belt. There is a system. But if you don't have this one, don't worry. If you have your clock, keep in the pocket, not in the wrist. This is a suggestion for you. In the previous slide, possibly you understood, though I didn't discuss, this is a t-shirt type dress. It is actually practiced in Sweden. Every health worker uses this dress with a distinct badge here, who is a doctor having the badge. But in our South Asian countries, practice is different. Doctor, nurses, and other having minimum the different colors also. This is the lack of the education. And now come to the station of practice and the consultation. This is a doctor, this is a patient. How to sit over the table. You see, they should be in the smiling face and a little bowing down towards your patient. It is called cooperative attitude, bowing down, attentive attitude. And the legs will be beside here, not very wide apart. Your hand will be like that by what I say, the interdigitation is there by the hand. And you see again, closer view, bowing forward. This is a sitting arrangement in the consultation time. And now look at another picture. This is the doctor and his patient. And if you want to criticize here also, who want to criticize here? Anything here? Who want to criticize? Can you raise your hand regarding this posture? It is for learning purpose, don't mind. Who will tell? Dr. Hanan, can you criticize here about this sitting position?
Speaking of the patient, it is her leg is widely separated.
Not separated. Her legs rather crossed.
Yeah,
So cross leg is not encouraged.
yeah.
Okay. Then
And also her hand in checking above the table, not down.
it is not so odd looking though over the lap or maybe, but over the table also not bad. But about this
And
long
the cover of the head, it is
long
down.
sleeve, yes, long sleeve is there. It
Yeah.
should be a t-shirt type minimum. If you wear the gown, it should be half sleeve. Okay. Any more? Hanan, any more? Any comment from others as well? Dr. Uzma, can you comment?
And
Dr. Mahbub,
and
yes.
any
Yes.
white coat should be, yes, sir, any white coat should be avoided.
Actually, don't like to
This is
say
white
that
coat here.
should be. Rather, this is discouraged. Quite good, discouraged.
Discouraged.
Don't like to say that a word. Discouraged. And any more? Mahbub? Dr. Uzma, please, your opinion. Quickly, we have to proceed.
No, I think it's fine.
It's fine. I think,
Yes.
sorry, doctor, not fine.
Not fine.
Not fine. We will tell also. Dr. Bakar, please. Dr. Bakar, your opinion. What do you think is the position regarding other thing? Do you like to comment anymore?
Well, only crossing
No,
leg.
no. Dr. Amal is there. Welcome, Dr. Amal, please. Your comment.
White coat.
Yeah, Dr. Amal. About this scarf, what do you think? This one, this cloth is a long cloth here, right? It will disturb the performance.
Yes, sir.
And about the hair, the tall hair, you see, is not well managed hair. It is not well managed here. So as much as we can, we have to actually follow the instructions how to prevent or control infection. It's important. It is important. And so I like to highlight here also this gesture, what we discussed. It is better to avoid it. It's better to avoid it. Right. Who written? Sorry, Dr. Uzma, I don't know why the voice is low. You can check again. Maybe the interruption in the net. Anyway, so this is another cross leg. This is the wearing here, I told you, this one. And this hand, this is the clock. Previously, it was allowed, but nowadays, nowadays, a very important issue in the COVID situation, you know, to prevent the infection. We have to be very cautious about this. So better not to use this wristwatch in that manner. Though crossing the hand is okay, like that. And now come to the case practice and looking at the patient. This is called the body gesture or the body language. Who can say what is the meaning of this type of body gesture when you are talking? Patient eyes are down. Can we get any clue from here, doctor? Anyone? Better to you raise your hand so that I can easily detect you who want to talk. Please raise your hand. Yes, Dr. Hanan. What is the message here?
This may be a depressed patient.
Depressed. Dr. Bakar. Dr. Bakar, your mic is given, please. Yeah.
Depressed mood.
Yes. This is the depression. But if patient always move the eyes up and down, it might be anxiety. This is another clue also, reverse thing. Good. Very good. So now again, if you though the South Asian countries there, baby will not be there, but ideal thing that baby should be in the lap of the mother like that. If your patient is baby, and on the table there will be some toys and others, doctor will be very attentive like that, going forward like that. Again, to comment here, sorry, that the hair arrangement is not perfect. Is not perfect in my sense. Better to keep with the cap better, or in the, what I say, in a group, to keep it in the very small part of the head and not to be suspended more. Okay. So this is the position in the table. You will be in this side. You will be within the hand breadth distance. Not face to face, not in front directly. Patient will be in the side part of the table. This is the position of you. In the practice now comes there, how to practice it. We will go little practice, but what may be the instruction in the examination? Maybe like that. Mrs. Habib presents to you clinic to discuss her issues. So actually, what if the issues not disclosed to you? There may be some hidden problem. Patient will tell you very privately maybe. So this is the flavor here. And you need consultation with examination in the management plan. So consultation, examination, if examination is not required, it is mentioned below. Consultation means only talking and make a management plan. This is one type of instruction. And another type is, Mr. Bhatt, 50 years old married man, has had abdominal pain for 1 day. So examination findings, usually vital findings are given there. If the relevant, some other findings also. And proceed with consultation, perform a relevant examination and make a management plan. This is a very prototype instruction. So if you discuss a little, the 50-year-old married man having pain in the abdomen for 1 day, we can think that this is an acute case maybe acute case, we can discuss later also. But as the first class today, I like to hear from you, as you practiced before also, how to start with, when you enter the room, how to start with the patient, how to say. So it may be a more information here from above down, you see. But in the MRCGP, a little modified, but these are very important somewhere you can use. So I have highlighted the first line and the last line, right? And somebody is to say, especially, may I request Dr. Bakar, please, how can you introduce your patient? Can you tell now, Dr. Bakar? Yeah.
Good morning, man. I am Dr. Abu Bakar as GB here. How can I help you?
Everybody is actually oriented this way. How can I help you? The last line. So did you get the permission from the patient to talk?
Oh, sorry.
You didn't think. No, I don't like to say you are wrong. And in the GP practice, usually in the exam also, we are doing the same. But my suggestion as a mentor to you, minimum take the permission. Okay. So it will not take more time, maybe 4 or 5 seconds more. in between also important in the consultation
Yes.
introduction, but in the GP examination, these are not much followed. So, but I like to hear as this. Oh, who can say now again? Dr. Uzma, please, can you say? The patient is Y, you are Mr. You are Dr. The patient may be X, you are Dr. Y, maybe. But Dr. Bakar response, I like to say that not Abu Bakar, you will be, I am Dr. Bakar. The last word you have to utter. Your last name to be uttered, not the whole name. So, Dr.
Okay.
Uzma, what is your good name, Dr. Uzma, complete name?
Dr. Uzma Ajmal.
Ajman. So, if you are recorded as Ajman in the Royal College application, so you have to use your name as Ajman.
Ajmal.
Ajmal. So, I am Dr. Ajmal, not Uzma. This is the courtesy by the last
Okay.
word.
Dr.
Can you?
Ajmal, how can I help you?
No, doctor, please complete as my suggestion.
Okay. I'm here
Hello.
to talk.
No, you start from the beginning. Hello, Mr. Rank.
Hello, Mr. X. Good morning. I'm Dr. Ajmal. I am here to talk to you.
Is it okay?
Is
Please
it
ask.
okay?
Okay, doctor, thank you very much. Then, how can I help you?
How can I?
Help you, right. Very good. So this is the practice actually. I think Dr. Mahbub can practice with me. Is that not like PACES exam? A little different. Shortly. Dr. Mahbub, can you practice?
Yes,
Dr.
sir.
Zaman rather, not Mahbub, Dr. Zaman. Please, Dr. Zaman.
Yes, sir. Hello, Mr. Osman. Good evening. I'm Dr.
Good evening, doctor.
Zaman here. I am here to talk to you. Is it okay?
Okay, doctor.
I came to know that you are suffering from some fever. Are you comfortable?
Sorry, Dr. Mahbub, no need to practice this thing. It is just written as
Okay, okay,
structured. You just say the first line and the second line.
okay, sir. Okay.
Can you repeat, please? First line and the last line.
Hello,
Zaman. Hello.
Mr. Osman.
Hello, doctor.
Good evening.
Good evening,
I'm
doctor.
Dr. Zaman here.
Okay.
I am here to talk to you. Is it okay?
Okay, doctor. Okay. Thank you very much.
So how can I help you?
Yeah, doctor. That thing, that complaint given that one day abdominal pain. So the patient will tell you that, okay, doctor, I am having pain in my tummy. You know the jargon in the meantime. What is the meaning of jargon? We should not use the medical words to the patient. So this is a very simple introduction in the MRCGP. And just for understanding, for the diagnostic purpose, we have to understand the presentation of the patient. The patient may present with the specific clinical features of the disease itself. Patient may present with the features of etiology only. You can think yourself in your leisure time. I'm just giving you the principle. Patient may come with only the complications feature, not the primary disease. Patient may come with the drug effect. Patient can talk to you for the investigations report only. Or patient may be a follow-up patient for the maintenance treatment. And some patient may come to you only for the general checkup. Patient is not a patient at all. So very often the drug effect and the investigation or the complication, these are very common, including the disease features. So in the MRCGP, in our case selection, we have given the importance each and everything. So how a patient presents it. Now, when we come to analysis of the symptom, suppose abdominal pain and other, suppose that was the symptom abdominal pain one day. So one day is actually confusing to us. One day is 24 hours. So how many hours? It is also important. It is not the 23 hours or 24 hours. Traditionally, we are habituated to write 1 day, 2 day. But if the symptom only within 1 day, better to ask about hours. How many hours? This is also true. So if any symptom as a prototype of the abdominal pain, if we know that how to proceed on, we created a mnemonic for you, OPD cats, especially OPD cats. As this is pain, we added one R. R means radiation. So if you go through, I think if we now a practice with these OPD or cats, you may reach to a diagnosis. It is possible also. So who can talk with me? Dr. Arif is now in the easy. Still, are you on the way, Dr. Arif? Are you, Doctor?
Sir, I will be free within 5 to 7 minutes, sir.
Okay, better. Can I ask Dr. Amal, please? Dr. Amal. Can you
Yes.
talk to me? Welcome, Dr. Amal. Can you practice this OPD
Okay.
and RCAT for the abdominal pain? Patient told that Mr. Bart, you can remember, married, 50 years old. He complained about abdominal pain for 1 day. Can you proceed only with this, not more than that? OPD or CAT, this thing. Dr. Amal.
Okay. Okay. How did it start?
Doctor, first, you can start from a little beginning. Yes, doctor, I am having tummy pain for 1 day, doctor. Please help me.
Sure, Mr. Usman, I'm here to
Mr.
help
Bart,
you.
Mr. Bart, don't forget your patient name. Mr. Bart, we have shown you before. Mr. Bart.
Mr. Pa?
Yeah.
Sure, Mr. Pa, I'm here to help you.
Okay.
Can I ask you some questions about this
Please.
abdominal pain? How did it start?
Actually, doctor, you have to say the tummy pain, not abdominal pain.
Tummy pain, yes.
Yeah. Can you repeat?
How did it start?
Can you repeat?
How did it start? How did your tummy pain started?
Yes, doctor. Suddenly the pain started, doctor. When I have taken my breakfast in the morning, then I got pain, doctor.
Mr. Ba, how does it progress?
Yes, doctor, it is progressing really. No relief in between. I tried some antacid syrup, but it is not giving me relief.
Can you show me exactly where is your tummy pain?
Okay, doctor, can you see me here? Patient is showing that it is in the right upper quadrant of abdomen. Okay.
For how many hours do you have this pain?
Last around 3 hours, doctor. This is the morning time. Then it's in the early morning when I take the breakfast, doctor. Around 3 hours.
Where does it go?
First question will be: Is it moving anywhere?
Is it going anywhere?
Yes, doctor. It is going through my back, doctor, through and through.
Can you prescribe for me this pain?
It's very severe pain, doctor. I cannot tolerate.
How is the character of this pain? I mean, is it sharp pain?
Sharp pain, doctor. Sharp pain. Sharp pain.
What make it better, Mr.
Doctor, I tried actually with antacid syrup, but it is not giving me more relief. Very little relief. But when I bend forward, doctor, I can get a little relief, doctor. If I bend forward.
What make it worse?
Actually, I didn't understand, doctor. It is already in the high pain, more pain, doctor.
Is it how does this pain is this pain aggravate or worsening in a specific time of the day?
Doctor, I'm a look at that you have only 3 hours pain, so this point is not valid here. Timing is not valid here. If it is a 2-day, 3-day pain, then morning, evening, night you can calculate. But here not possible. Clear?
Yes.
The
Yeah,
timing,
more than 1 day.
One day, then you can ask. So especially for all of them, please remember, all the points may not be valid for each symptom because the duration is not that much. This is one thing. And the timing means actually that diurnal variation. Some pain may be more in the morning, after another for that. So it is not the timing here important here, but the last point is severity.
Yes, Mr. Bar, in scale of from 1 to 10, 1 is minimal pain and 10 is maximum pain. Where you put your pain?
It may be Dr. 7 or 8. Okay,
sorry for
Amal.
that. It is really severe.
Oh, thank you, doctor. So Dr. Amal actually shown her sympathy also to the patient. That's good. So up to this, any query in your mind, doctor? All of you, I am asking, please raise your hand if you have any query up to this practice. Possibly you know even then for your refreshing. Any query? I think you understood that. We can proceed.
Sir, associated symptoms.
No,
The
we are
associated
not
symptoms.
practicing associated, Dr. Arif. We are not practicing associated symptom. We just practice only OPD or CAT, not beyond that.
Okay. Okay, sir.
Okay, Dr. Bakar, please.
Doctor, according to severity of the pain, according to score from 1 to 10,
Yeah.
in the exam, what is the score? It is better to say for the patient, I will give you analgesic now, painkiller, like that.
It depends upon, especially the severe pain, you will tell the analgesic. Severe pain. Severe means it may be the 8, 9, 10, around like in that area. Not bad. Okay, any query? No more. So good. So now what is the diagnosis, Dr. Bakar? Because you see only one sentence is enough to describe the OPD case. If you know, you can tell, Dr. Bakar. What may be the diagnosis? Apparently,
Maybe acute cholecystitis.
could be, or as a bending forward, relieved by an
Col-
pain. More likely this is pancreatitis, not
What?
cholecystitis. Pancreatitis, because this is
Okay.
throw and throw pain. Throw and means from front to back,
Okay, yes,
and
yes.
less relieved by, and thus it means it is not peptic ulcer problem.
I hear right upper quadrant.
Upper quadrant or the epigastric pain also, right? Upper quadrant may hint you that this is cholecystitis, but pancreatitis pain also patient may indicate in the upper right upper quadrant also, because
Okay.
head is there.
Okay.
So what I like to say that in the first 1 or 2 minutes, you may be able to diagnose your case. And most of the stations, it is as live. So diagnostic challenge will not be more and more in each station. Diagnosis will be a little easier because this is a complete examination station. Examination means to evaluate your patient. Finally, you have to give investigation plan and you have to give some management and others also. So examiner is to assess your that skills as well. For that, diagnosis will be very easier. Unfortunately, if you miss to diagnose, the later performance will be bad because you will be wrong in your investigation planning. You will be wrong in your management planning as well. So diagnosis will be easier, and I hope that everybody will be able to diagnose from the surrogation in our course also. I hope. So this is very beginning part. It's very important part, rather. And if we formulate a structured history taking sheet, it may be as such from our side, from our institute. You can see that already possibly provided to you, or within 1 day also we can provide to you also this type of materials. You see that this is a greet and meet already done. Hello and others. The presenting complaint. So how to analyze the presenting complaint? First, OPD cares already done. If the pain is there, R will be in between. The second question, suppose if this is the abdominal pain, from the OPD cares, we understood that this is the alimentary system issue. So what will be the next question? Ask other symptoms of the relevant system. Dr. Amal, what will be the next question in this patient?
I will ask about the red flag, and I will ask about the associated symptoms.
No, what we mean by the relevant system, other symptoms. Red flag may be in between also.
The GIT,
GIT. Can you tell some
symptoms
symptoms?
like vomiting,
Yes,
throw
vomiting.
up,
Rather to say throw up, Dr.
feeling
Amal.
sick or being sick. Feeling sick. Are you feeling sick?
Yes.
Are you being sick?
Okay.
And now, how is your bowel work?
What about your bowel? Okay.
Work.
Okay. Okay.
Yes.
Good.
Any losing motion, any blood, any black stool.
Okay. These are the red flags, definitely. These are the red flags.
Any weight loss.
So weight
any
loss,
high
doctor.
temperature.
Weight loss, doctor. We have to keep preserved in the general health query rather, not in the GI symptoms. Better to be in the general health query. So each
when I will ask it
in the general health query headline.
Because I used to tell all the red flag together عشان never mind cannot forget it.
No, you can ask in your own way, no problem. But according to the structure shown to you, just I am telling about. You can ask anytime. So what are the red flags? Actually, in a dangerous disease, malignant or other disease, patient is losing weight, right?
Yes.
If
Yes.
if an infective disease,
Fever.
patient may have fever. Okay.
Fever.
So this
A high
fever,
temperature.
weight loss could be in the general health query.
Yes.
And in the general health queries also, the list may be an expanding one, maybe any bleeding anywhere. It's
Yes.
hematologic disease. For some other
And
reason.
gluten.
So this is called general health query A, B, C. But finally, we need to know about other systems informations also. It is called systemic inquiry. The last 9 point you see, the lower one, 0.9. So in the practical situation, the other systemic inquiry may not be possible in the first 1 or 2 minutes time because it is not more important in GP because GP is challenged with the diagnosis. Listen to me. If you need, you can again unmute yourself. The thing is that in the A, OPD gets and the ask other symptoms of the relevant system. Up to these, more in the most of the cases, enough to diagnose the case. About the red flags, maybe there means the relevant system informations and maybe the general health code, especially fever and the weight loss. Always must not be missed information in the consultation. But for the 1 day problem, now you can think it is only 1 day problem. Patient is not losing weight, but patient might have fever. This is the intelligence of a doctor. Should I ask or not? But if patient telling that I am having tummy pain, but was he quite okay 1 day before? This is also true. What we ask, is it that you are okay 1 day before? Don't you have any problem? We have to be clear. Patient is losing weight for the last 1 month, but suddenly patient having the abdominal pain. It may be also the case. So we have to be clear that patient almost reasonably well 1 day back. Then patient develops suddenly right upper quadrant or a pediatric pain. It may be the case. So it is the acute case. And now come to the past history. You have seen this. I think you know about that. In the practice session, you will hear. To highlight these some red words, impact of symptoms in life. Impact of symptom means it is impacting how it is impacting your daily life, in the job or in the home. And the idea, concern, expectation. It is very, very important. The last word is a summary of the history, how to summarize. In the MRCGP exam, actually, time is not allowed to let your patient to tell or you are telling. So summarization may be important sometime, but you have to take very less time, not more than 1 minute, or even within 1 minute you have to finish summarization. But important thing is to ask the patient 2 questions. Do you like to ask anything else? Do you like to add anything else? It is better. But in the station 10 minutes time, if you have time, but in our last experience is telling us that summarization, we may not have enough time. Sometimes it is not possible. So summarization, you mean the salient features of the patient. Intelligently also, you can tell summary within 30 seconds. That what I came to know from our talk, you might have a disease, finish. You might have a disease, I am thinking. And do you like to ask anything more? Do you like to add anything more? Later also you can ask, or before also you can ask before summary. But in my suggestion, to ask the patient, do you like to add anything more? Do you like to ask anything more? Is a very tremendously effective attitude, because you may not ask something very important from the patient, but patient is waiting to tell you. So if you give the chance to the patient will tell you in the examination. So it will be very fruitful for you. So it is a habit. Now come to the second box, especially for the baby. What about the immunization? How to ask? Who can tell? Can you raise your hand? Immunization. Yes. Dr.
Like,
Ozma.
sir,
Dr. Ozma, please, maybe.
How's the vaccination schedule? Are you completed your vaccination schedule?
Okay, this is one type of asking. Dr. Arif, please. Dr. Arif.
sir, like adult vaccination, like influenza and
No. How to ask the
pneumococcal
question.
vaccination.
How to ask the question.
Okay, have you completed your vaccination shots? Have you completed your vaccination shots in childhood, and what about your recent vaccinations?
So you are asking a lot of questions. 2 more questions. Dr. Bakar, please. How to ask?
Is your child vaccinated up to date according to his age?
Vaccinated. Dr. Zaman. Vaccinated.
Have you completed your vaccination?
Sorry to say you. The layman term will be shots, not vaccinated, not vaccine. Shots.
Okay. Have you
finished
completed your shots
shots?
in childhood?
Yes. Have you completed your
Have you
shots?
finished your shots?
Finished your shots. So Dr. Arif utter double word. Vaccination shot.
Short or shots?
Shots, plural, whether to say plural. Shots.
Okay.
Plural. Okay.
Shots. Usually child given minimum 6 vaccines, right? You know, more than 6 also nowadays. So Dr. Uzma, clear to you. Shots. It is not the vaccine. This is not the vaccine. So I like to advise you also, as provided to you, you can see maybe the video link given to you, the layman terms in the YouTube. You can see this YouTube video link. Maybe 2 hours more you have to see. Most of the layman terms are described there in the video presentation. It was interactive as well. You can enjoy. Okay, so this is the shots, immunization. But in the pediatric population, must, if you miss it, it will underscore you, the population of the baby. Shots. Anyway, in the formulation of the diagnosis, this is an attitude we actually have taken from our side, that the rule of 2 for the diagnosis. How, for example, breathlessness is a features of the heart disease as well as lung disease mainly. But if the breathlessness is associated with the cough, your disease will be in the respiratory system. If the breathlessness is associated with the chest pain, central chest pain rather, or the palpitation, it may be the disease in the cardiovascular disease. If the patient having no cough, no chest pain, or no palpitation, the breathlessness may be metabolic one due to renal issue, and it may be functional as well. So this is one of the way of summarizing a diagnostic planning. Minimum, you can tell that the disease in that system. For that, we develop a rule of 2. So it may be very helpful when we come across, you will understand. And but I like to ask you now, if I tell that the breathlessness with cough, what will be the specific or core feature of the respiratory disease here? Dr. Mahbub, Dr. Zaman. Suppose breathlessness with
Please
cough.
ask the question again.
I'm telling that breathlessness plus cough, you are thinking that this is a respiratory illness. So quiz question to you, that which feature is actually more specific for the respiratory disease? This is the breathlessness or the cough?
The cough, I think.
Cough. Dr. Ozma?
For respiratory disease.
Dr. Ozma?
It's dry or wet?
Whatever the dry or wet, I am telling about the cough. Breathlessness and cough. So is the breathlessness the main important symptom for the respiratory disease or the cough?
Yes.
Which one?
Respiratory.
If you think that this is respiratory disease, so breathlessness is the important symptom or the cough is the most important symptom?
Both important, but breathlessness is
No. Breathlessness may happen in the heart failure also, right? Most of the time. But the cough, almost a sole feature of the respiratory disease.
Okay.
So likewise, palpitation will be the core feature of the cardiovascular disease. That means the heart. That's the thing always we have to search, not in this OSCE exam, rather in the part 1 exam or anywhere. If you consider the symptom analysis, you have to analyze in that manner. That what will be the specific feature of that system disease. So Dr. Zaman is very, very right. Cough will be the specific feature of the respiratory illness, not the breathlessness. So we have to identify such symptom in each systemic disease. Clear, I think, all of you. Huh? So this is now a little break time for you, 1 or 2 minutes or so. If you want to discuss, please raise your hand. Don't suddenly talk about this. Raise your hand, please. You cannot unmute yourself. Please raise your hand. Yes, Dr. Bakar, please.
Doctor, sub question. You say in the first session, in the first picture, when there is any,
Sorry, again, you become unmuted, please. You muted.
you say in the first picture, when there is any device in the case, should be used in the case.
It is assumption. More likely, you have to use. Use means talk to the patient about patient can use it or not.
If you will not use, you go with wrong direction.
Yeah, wrong direction. Usually, what will be the device? You have to know also. Commonly, the inhaler for the asthma patient. That means you are facing an asthma patient there. If you see inhaler there, right?
Yes.
Most of the time, this is the inhaler for the asthma patient. Or if any diagnostic
According to
there, it may be peak flow meter also sometime in the asthma station. Peak flow meter. You know that peak flow meter can be utilized in the chamber, right? Peak flow meter. Yeah, Dr. Bakar, any more? No.
It's about the pediatric case in the exam. Should be real here child or
No. It's South Asian mother or father or brother, someone will give the proxy of the baby. This is the trending. This is the trending in the South Asian exam. So we will practice in future. You can see how to do it with the pediatric. Okay, I think no more question from your side, and we can proceed now further. Huh? Thank you very much. Now come to few talks on this examination scale. So let us see. I will touch how to introduce for the examination. So you took the permission from the very beginning. I am such and such. Is it okay? I am talking here and okay. So if you want to examine again, try to have some permission further because you are examining. In very short, we can say, I will touch and listen your right chest or tummy or whatever you say. Always ask about the pain. Do you have any pain anywhere in this moment? During examination, if you feel any discomfort, please let me know. I will take care. It is assurance. Because whenever you palpate somewhere else, patient may feel pain. This is fact. But in the MRCGP again, most of the time you don't need to examine, or you need to examine means very few signs you have to elicit, not whole. In the chest, most of the time you have to actually auscultate. Remember, what will be the philosophy underlying? If you percuss the chest, patient may feel pain. They are the healthy people, they are waiting there. In the 14 station, 14 doctor will percuss over the chest. Maybe it is comfortable for the patient there. The patient means the healthy people. So you mean that thing that auscultation will be comfortable for all patients. So if you have information from the auscultation, it will be the focus examination there. If you need to do it. This is a technique I am telling only. So auscultation may be the focal examination for the respiratory system. And in the neurology, maybe the jacks only, but jack may be irritating. The plantar response, you know, that is irritating. So actually, they will not allow to do it. But you have to tell that I will see the plantar response. Then examiner or surrogate can tell plantar extensor. So these will be practiced with you in the coming session. So this is the introduction and the examination philosophy I told you. So like that, this focus examination may be important in this main system, chest, abdomen, cardiovascular, nervous system, and the relevant general examination is important. So you need to start from the hands, hand muscle status, anemia. Anemia not important. Anemia to be seen in the conjunctiva though. You need to colonychia, leukonychia, other. But we have to think that these findings searching is important for the symptom related with the patient or not. Suppose you are facing a respirology case, patient having cough with productive sputum, definitely clubbing will be the most valuable finding in the hand. So if you in the hands, you go to the leukonychia, colonychia, many things, it is not actually what I say valuable one. Rather to check the clubbing is important, and you know how to see the clubbing very classically. You have to practice it how to see the clubbing. So this is your skill. And the neurology mainly 5th, 7th cranial nerve sometime you need to know. And the knee, shoulder, some joint examination is also important, especially the carpal tunnel, diabetic foot, not too much important, diabetic foot. And easily simple will be the carpal tunnel. Back may be there for the restriction of the spinal movement. And the wrist, again the carpal tunnel related. Elbow, there may be periarticular disease also, that frozen shoulder, maybe the shoulder. In the wrist is the golfer's elbow, tennis elbow, like that. Neck, especially the thyroid gland examination is important. So these are very, very important. More likely examination to be checked in the OSCE, and sometime examination not needed mention also. At that time, surrogate will tell you the finding. And especially this maneuver will never be done by you, and usually was actually not instructed before, because if you put some otoscope inside the ear of a patient, it may be injurious for the patient, or the patient or surrogate there. But you have to know about the findings, because they will show you the picture of the findings, the fundoscopy picture. And if you go for the otoscopy, the ear drum picture will be there. And the per vaginal examination for rectal is very, very private part examination. Actually, will never be allowed to be done this thing. But you have to approach it, and the finding will be uttered by the surrogate. This is the strategy in this station. Okay. And all the examination always have actually been divided into two parts: the related general examination and the focused examination. Focused mean local or systemic examination, but not all of these: inspection, palpation, percussion, auscultation, not all. You have to select some important findings from these four headlines. Always inspection is actually harmless for the patient. It is not injurious. So inspection is mandatory, plus maybe the palpation, maybe auscultation, or both. But not everything, especially abdominal case needs everything. So surrogate can actually act well also. Like upper quadrant pain, whenever you press there, patient can shout, patient can winch also. So acting can be done easily. For the abdominal needs, most of the maneuver of the abdominal examination, inspection, palpation, percussion, auscultation. But in other part, especially the chest, you don't need to go for all the inspection, palpation, percussion, auscultation. Only focus examination according to your history guidance. According to your history guidance. So if you come to the abdominal pain one day, again, it is found that Dr. Amar told to the patient told that it is a 3 hours pain. The right upper quadrant, we are suspecting it may be acute pancreatitis. So how to proceed on, that palpation, if you want to do from the below, lower part of the abdomen, not in the apical, the epigastric area. So you have to come to the painful area later. This is also principles of examination. It is part of the patient's welfare. So this is a very, very principle of examination. Okay, now a quiz given to you. Suppose this patient, you are talking about her problem. Patient was actually losing weight, and she told you that I am having a problem of my neck, and I am taking some medication now. Patient may tell something to you or may not tell also. But just to test you, if it is a picture in front of you, what information you are gathering from the picture? May I ask Dr. Ozma? Can you tell, please?
Yes, there is some scar showing.
You tell me the clinical information you are gathering.
No,
Scar means what is this? Scar
there
means,
is a black shadow, black mark on the neck.
what is the meaning of that?
Maybe there is a pain. That's why they put some.
Dr. Ozma, if the scar is as such, does it mean that some operation done before?
Yes, I think so. But
What operation? What operation?
thyroidectomy.
Okay, if it is thyroidectomy, now question is, what was the reason of the thyroidectomy? Can you guess something from here?
Yes, we can ask. Did you get any operation?
No. Without asking, doctor, I am just testing the picture analysis of this.
Okay,
That is
okay.
still not asking. Who can tell? Raise your hand, please. Who can tell?
We
Yes.
can check the skin erythema, swelling of
No.
the neck.
Only from the neck also. What may be the reason? There is some marking also, Dr. Hanan.
Maybe this radiation from radiation.
It's the
Burning
radiation
from-
area. If it is a radiation is there, so what may be the etiology?
Yeah.
Dr. Zaman, what may be the etiology?
Yes, so I think, sir, it's a case of thyroid malignancy, and after doing thyroidectomy, radiation treatment has been done there.
Yeah, you are right. Dr. Bakar, please. Do you have the same opinion? Dr. Bakar.
I think the cause is malignant.
Malignant. So radiation was telling that this is malignancy. Dr. Arif, do you like to add something more?
Yes, sir, I am on the same opinion. If there was no such mark, I would like to go for another diagnosis, like for thyroid removal for tertiary hyperthyroidism on CKD patients.
So why you are going on the
Apart from
CKD
malignancy.
again? There may be some other thyroid disease also. It needs thyroidectomy. Dr. Arif.
Yes, sir. Apart from malignancy, I would my second differential was if there was no marks like this. If there was no mark like this.
It could be Graves' disease also. Sometimes Graves' disease needs removal of the thyroid gland. If the
Yes,
drug
sir.
is not working.
Yes, sir.
It could be multinodular goiter also, right?
Yes, sir.
Multinodular. Even it is not malignancy also. Sometimes the thyroid nodule also will be removed before turning into the cancer, right? Dr. Arif? Sorry, Dr. Arif. If the thyroid nodule also, before turning into the malignancy,
Yes, sir.
we remove the thyroid nodule. So at that
Yes,
time
sir.
also there may be no marking like that. Is not it?
Yes, sir. Yes, sir.
So many thyroid reasons are there. So we have to think about that. Why we are going to the CKD that make a hyperparathyroidism or whatever tertiary. So as an internist also
Maybe,
we
sir,
can think, but as a primary GP, actually GP should not think beyond that. Better to be the safe side.
Okay, sir.
So think in the primary illness of
Okay,
the
sir.
thyroid gland. So any next question, everyone. Dr. Amal, what is the meaning of these? These rope. Amal?
This is something due to tradition or religion.
Religious what?
Uh,
Religious rope.
They think that they can put it, they save themselves.
Okay.
In Arab, they tell tamima, something like it is not, it is haram in our religion.
Yeah, it is religious in haram, but some in the South Asian people also using this. You know what else people are using?
Tamima.
Tawiza.
Tabiz.
Tawiza, tamima.
Tabiz in our area. Anyway, other than tabiz, what we use, Dr. Zaman, other than this in the illness? Hair.
Sorry, sir.
South Asian people using this type of material other than the tabiz or that other than this thing. They are using what else? Other material? Hair. Have you seen the hair in the leg or in the hand?
Oh.
People wearing the hair, long hair. So actually it indicates what I say, the
Yes, sir.
prejudice. Another thing is long-standing illness. Usually people use such material in a long-standing illness, in chronic illness, not in the acute disease. This is also hidden information here. So Dr. Uzma, you started with the talk of the picture. You know how information is actually how much you gathered, right? Dr. Uzma, can you hear me?
Unmute. Yes, doctor.
Okay. So again, it's still remaining some other information also here. Dr. Uzma, what may be the age of this patient?
Age of the patient is 25 to 30.
Maybe around
Not
like
old.
that. Not when
Yes.
70, 80, is it?
Yes,
Right.
is a young.
This is also message. As I stressed here, it means that in the OSCE station, whenever you are given a picture so that you can easily identify many problems. That's my intention actually, to take more time with the picture. So I think these are clear for you. Thank you very much. Thank you very much. Now coming to the next slide. Now, what actually the last part after your history examination, you are given last 2 minutes. You will hear that 2 minutes left. So if it is 2 minutes left, you have to check that is some important things you have missed. That means in the talking, did you miss that to ask about the patient's impact on the patient's life, effect on the patient's life? Second, idea, concern, expectation. These two very important. Idea, concern, expectation, special interest in the MRCGP exam. Then whether they have any questions of the patient. That's the thing. Do you like to add anything more? Do you like to ask anything more? In these last 2 minutes, very rapidly you have to ask it, because in the last 2 minutes you have to be busy with the management plan. Or if you can finish your talk in the 8 minutes or 7 minutes, you can get 3 minutes time. You are very fortunate. But in most of the time, when you heard the word, the 2 minutes left, you have to be very hurried. It is the wrapping consultation and driving issue. Don't forget about driving, especially in the occupation area, the social history. If the fever patient travel history, there is something. Now in the management part, in the consult, during the talking, you have to think gradually in between the talk to the patient, what may be your diagnosis, what are the differentials, is anything very active? Suppose abdominal pain is active problem now, but patient is diabetic and hypertensive. It is a chronic problem, but it is not active one. Okay, and you are thinking, what is the reason of that? I am telling this is active, and any complications now patient having. Suppose you are dealing a diabetic patient. Usually diabetic patient is asymptomatic most of the time, but patient may have the symptom of peripheral neuropathy. Patient may have symptom of retinopathy or many things. So in any disease, look at the complication. The final thing is that how to investigate the case further and how to manage the case. So these are the basic things to be discussed with the patient. So it is in the last 2 minutes part, you have to be very tricky. And in the management part, the principles are as such. Explanation to the patient about the disease and the concern as well. You have to need to explain the concern, patient is right or wrong. And the reassurance that every good thing should have every bad outcome will have a good outcome also, right? Two parts of a coin. So always you have to tell, right? Suppose if a glass is filled with the water in the half of the glass, you can tell that the glass is half filled with water. You can tell that this glass is half empty. It is your matter how to tell. So for the patient, actually, you have to tell good thing as well, not on the bad thing only. And the health belief also important to accommodate in your thought process to tell your patient also, right? Most of the time, people having the problem of the belief issue is mainly in the treatment of asthma with the inhaler. Patient may think that inhaler is not very good for to be used for the long time. Okay, and other issues also patient may have in their mind. So we have to think this health belief of the patient. Collaborative management, this is very, very important. The consultation is told as the patient-centered consultation. Patient-centered means patient will be the actually leading in the consultation, but you are the controller. Patient leading means patient will raise the issue, you will respond there. This is the patient. Whenever patient start to talk, you have to be silent. This is the patient-centered consultation. And even the management also, if you advise something to be done as the investigation, patient can deny this. You have to accept this. You can motivate the patient, so no problem. Finally, in the explanation part, you have to follow the 3E model. 3E model means explore first, then explain, then again explore. First explore means how much you know about this. Suppose the diabetic patient, we need to ask that, Mr. X, how much you know about the diabetes? How much you know about ischemic heart disease or heart problem? How much you know about other disease? Okay, patient can tell few seconds. Then you explain the second E about the disease, but don't take more time, remember. You can explain a disease half an hour, you are the master, but doesn't mean that you will kill your time. So, few seconds in few words, this is your practice actually will make you perfect. How to tell everything, exploring management, it should not cross 1 minute. Rather than 30, 40 seconds or at best 40 seconds is explanation. So after this explanation, finally explore. usual thing, expect that explore means you allow the patient that Mr. X, can you tell me what we discussed? But in the exam situation, you don't have time. So how to overcome this? The trick is asking the patient, is it okay? Is it okay? Like that. Am I clear to you? Is it okay, miss? Whenever you tell some sentence or decision, you ask that, is it okay? Patient will tell, yes, doctor. Yes, doctor. So no need to go detail about the 3E model, but the principle is 3E model to give any information to the patient. Okay. In the last part, you have to decide today you need the patient hospitalization or not. You need the referral right now or the later or not. You know, the GP, different types of the referral, routine referral, emergency referral, urgent referral. You have to decide that you need this type of referral. Follow-up date 2 weeks after, but in between safety netting. It is again extraordinary things to be discussed or tested in the exam of MRCGP radar. Safety netting. Who can say about the safety netting, please? Anyone? Raise your hand, please. Just to tell me about the safety netting. Please. No one. Sorry. You have to raise the hand. Yes, Dr. Arif, welcome. Safety netting, please.
The safety netting is the advice regarding the disease, its red flags, and the measures to take when time of emergency, and when to take the measures, and where to go, like in the emergency room, and including the emergency room phone number there. And these, in short,
That's
these
enough.
are
That is enough. You told about the red flags, especially if patient having actually again how to save the time, how to save the no need to tell the details, everything about. If you tell minimum that if you have any problem, that means you are talking today patient about telling about some problem. But any change of the problem which is bad, immediately call to the hospital or come to the hospital like that. It is in
yes, sir.
between time before the follow-up date. This is called the safety netting. Suppose you are giving a painkiller. Patient may develop a gastric pain, right? Due to acid peptic disorder or rather to say irritation by the acid to the stomach, peptic ulcer problem, dyspepsia. So these are side effects develop. So patient is to respond to the doctor to combat this thing in future. But you have given the follow-up date 1 month later. So what patient will do in between this 1 month time? This guidance is called safety netting. It is very extraordinary in the exam. Anyway, if you don't have any query, you can lower down your hand, please. Please check your device, lower down. Dr. Uzma, you have any query? You still are having the raised hand, Dr. Uzma?
Yes, I feel that safety netting, we can explain the red flag also.
Not all the red flags, but a little. So if you actually, practically, you may not have enough time to explain every red flag. So in general, if you tell in generally, if you have any problem, please come to the hospital or call over telephone to the service center somewhere. It is easier. But for some diseases, special diseases, you have to
Yes.
tell about some red flag also, though not a generalized, but some important disease. We come to know in the practice session which disease you have to tell about some red flags. Most of the time about the drugs, if drug will have potential of producing some dangerous outcome, you have to alert the patient by telling the safety netting also. Dr. Hanan, please, any query?
Yes, about here the eyes and when you do the eyes after history examination or during the history.
After
About the
examination,
eyes.
better. After examination, better, because if you
Yeah.
need to explain the eyes, if you need to
Mhm.
explain the eyes, you have to examine the patient first. Be confident about the diagnosis and other issues. It is better. But if
So after I
examination
finish
after you exam, yes, finished, then you can tell the eyes.
and the summary also after eyes and summary after finish history and examination.
No problem. Summary also after examination also.
Okay.
But if your examination is not allowed, then in the last part of the history taking.
Okay. Okay.
And finally the health promotion. especially health promotion issue, smoking and the alcohol. Always we have to ask, do you drink alcohol or do you
Okay.
smoke like that? But any other health, especially obesity is there. So are you, that the lifestyle issue may be there, but more commonly the GP, the alcohol and the smoking history. Patient is not telling you, but point is very important. If cardiovascular disease is there, definitely smoking history most important. But in any disease also, as a bad health behavior, we can ask, do you smoke? It is called
Okay.
opportunistic health promotion. Opportunistic health promotion. So if you want to do up to these, up to the health promotion, 23rd point I am telling. So you have to be skilled enough to talk to the patient. Within short time, you have to finish your information. So without practice, you cannot tell. So this practice session designed and intended for that. So be serious about that, especially for your time management. So how to talk very short, it is also part of our practice. You may ask one question in a very long sentence, but you may ask one question in a very short sentence also. So we have to adopt the short sentence, not the long sentence. Finally, at the last part, suppose you are explaining your findings or you are asking or talking something, but patient may tell you that, doctor, you have said I have this disease, but what about my that problem? It can give you a clue that you are maybe in the wrong track. Otherwise, why surrogate is asking about that problem? It means that you actually couldn't correlate the problem with the diagnosis. So this is a trick. It may be the trick sometimes. So you have to be very careful at that time that you possibly might miss something before. So if it is in the last 2 minutes, be hurried also to ask about these things. But sometimes you may be very unfortunate. You cannot get the clue. Very unfortunately, you may get very minimum score on that string. It may happen also. So, but I like to tell you the tricks. Sometimes surrogate uses it. Surrogate uses it. But some surrogates are very critical. Maybe they design in that manner. Surrogate will tell you nothing. Some station like that also. You will be very unfortunate. You will be very unfortunate. So that's all a complete examination description from my side and how to make a, what I say, the evaluation sheet. You can see there. We designed from the dorms as such. In the left box, these are the history information. In the female, you know that everything. And this is observation and the examination part, especially the general one. General observation and the general examination. See something only visible also, there, no need to palpate also. Many findings. Focused examination of the system. Bedside test usually not done in the OSCE. Bedside test means urine for the sugar, urine for the blood or other. It's the bedside test. Sometimes ECG will be the bedside test also. These are not more expected in the general physician's examination, but in the advanced some internist medicine examination, especially in the patients, sometimes you have to tell that I will do this, I will do this. The finally, in the right side, the handshake, and nowadays handshake is prohibited, and the introduction only. A general appearance already we discussed here, hands and radial pulse, face, mouth and ears. Sector wise, you have to proceed better, so you will not miss anything. So from starting general observation, hand, then go up to the neck, then the thorax, abdomen, lower limb as such, neurology mainly in the lower limb, cranial nerve. Sacral edema is important. If you need to exclude the edema, you are not getting edema in the ankle. So you have to check the sacral edema. Again, in the GP examination, patient may be in the sitting position, so don't need to go to the back. But keep in your mind that you have to see it. And this is the vital sign, blood pressure, temperature, height and weight is the BMI issue. Dip the urine. This is the bedside test, dip the urine. So again, not much important, but especially for the diabetes and the nephrotic syndrome, dip the urine may be important because you have to have an semi-quantitative idea of the protein material, protein amount in the urine, 1 plus, 2 plus, 3 plus, like that. So in the left side, investigation planning, management planning, The pediatric bind, B-I-N-D, remember this bind. So this is Doam's OSCE planner. Just keep in the mind, don't remember every point. If you have a look many of the time, so it will actually be helpful for your memorization. One time you can write down by yourself in the paper also. Now finally, how to manage your time in the history and examination. Please follow me. Total 10-minute time, you can utilize 5 minutes for the history plus 3 minutes examination. But you can overlap. When you examine, you can continue some talk if it is possible. Yes, it is possible in some time. You are looking at the anemia, but you are asking something also. It is possible. So 5 minutes plus 3 minutes examination, 3 minutes, and the history 5 minutes. Okay. So you already spent 8 minutes time. You will hear the 2 minutes left. So next 2 minutes, you maybe 2 minutes or 3 minutes. If it is suppose the 5 minutes, it will be 7 minutes. You may get 3 minutes. You can finish, or you can overlap. But my suggestion that try to spare 3 minutes later in the management part and other. It will give you pleasure, a smooth ending of your consultation. Don't wait that examiner will tell you 2 minutes left, then you go for the management. Try to start your management plan before warning bell. That means the 2 minutes left. So that is the thing. This is the, but again, as a human, we are actually talkative doctors most of the time. So we may spend up to 8 minutes. Anyway, so this is the time and the 3 minutes as well. Okay. So these 3 minutes actually the examination purpose, the 2 minutes the management plan. Okay. So this may be a combination of the timing, and in the management part, you have to be ready to give this answer. There are few questions in the mind of any patient. The traditional throughout the world. Name of the disease, patient may not ask you, but you have to tell. So patient may not ask many questions. If you have time, you have to give the answer by yourself. Single way. You are telling everything. Patient, if female, they will ask about the marriage issue, about the conjugal life, about the baby. The disease will be hereditary or not, like that. And the chronic disease, they will ask, doctor, how long will I survive? How long will I survive? So how you tell in your practice, Dr. Ozma plays in. Did any patient ask you like that, doctor, how long will I survive for any disease, any time?
It's quite early to say, Mr. X. Actually, we will wait for the result and we will see that how your lab result will show what kind of disease you have.
So your answer is right in some diseases and most of the diseases, but sometimes your answer may not be right. For example, you are seeing a patient, ascites and encephalopathy, right? Patient having development of the hepatocellular carcinoma also in the top of chronic liver disease. Do you get my point, Dr. Uzma?
Yes, yes.
So patient vital sign also going down. Patient with grunting, right? Respiratory distress is there. So will you tell this patient attended also the same ward?
No.
That is very eminent at the end of life care. So in that case, how to say? You think that patient may die within a week or within few days. You know it. You know it means you are gazing. Almighty will set everything. But how to tell in this patient? So you can think, Dr. Bakar, please, you can share here. How to tell? Patient is imminent for the death now. Death is imminent. How to tell, Dr. Bakar? Dr. Bakar, I am giving a mic to you. Yes, please. You can unmute, Dr. Bakar. Please unmute. Bakar, sorry, doctor. Can you unmute? May have problem? Yes, Dr. Arif, please. Dr. Arif, how to tell? Death is very imminent.
We should tell in this fashion that although your disease condition is advanced, but we can't confirm that how many days you will be alive. but we will assure you about our support till your last moment
Arif,
through any
again,
of our medicines.
yeah, Dr. Arif, you are right in your content of the talk, but again, you are taking long time, Dr. Arif.
Okay, sir.
So try to tell in very short words. And especially for the terminal care, critical illness, you have to tell to the relative, not the patient, right? The patient is dying within 1 or 2 days. So better, it is practical that to tell it to the relative, what was the son of the patient. So it is very early to say it is one man. Another thing, I am very sorry that time may be very short. Clear, Dr. Arif? Dr. Arif, I am very sorry to say that time may be very short.
I'm very sorry. Yes, sir.
I am
I
very
should have
sorry to say
started this
that
session.
time may be very short. That means patient may die within an hour or day. Clear, Dr. Usman, now
Mhm.
you
Yes.
Yes, yes.
in that manner. So it depends upon. But thing is that we should not fix a date or after 7 days patient will die. We don't mention this months or weeks or rather to be very qualitative that early or later, few days like that. Not fixing the days is important. Okay. For example, you see, my other colleagues in the right side, you can see, but you may not understand this language in the left side. So it's a snapshot from a paper. You know that this gentleman, Dr. Bakar, do you know this man?
No,
No? Who sees, who knows him? Dr. Zaman. Zaman, I think he knows.
Stephen Hawking.
Is Stephen Hawking, the theoretical physicist. He died, maybe 1 year, 2 years, 2 years before. So, according regarding telling of prognosis, I am talking about. This scientist was told that he was Dr. Bakar. Do you know what was the disease he was having? Stephen Hawking, motor neuron disease. Motor neuron disease. So, motor neuron disease usually the 5 year or 6 year after patient may die. It was the truth. So, doctor told that Mr. Hawkins, you may accept the euthanasia. That means it is called the suicide. Suicide, what is called? Legal suicide or like that. Euthanasia. Euthanasia means the suffering for that to overcome the. So doctor told that you may live only 2 years later. Anyway, how long? The question was. Forget about euthanasia or something. So doctor commented that you may live 2 years, but he survived more 55 years. So as a doctor, we better not to tell in that manner that Mr. X or Mr. Y you will survive 2 years, 3 years, like that. Rather to say a few years, better to say, not by 2 or 3, few years. Yeah, Dr. Bakar, any query in your mind? You're given the mic, please, Dr. Bakar. You can unmute now.
the correct answer of how I will survive for critical case. Better to say short,
I'm sorry to say that time may be very short, like that.
only like that.
Yes. But all critical care doesn't mean that the life will be ended. If you have there a chance of recovery, so you will be very hopeful. But you think that time actually the time after 1 hour, 2 hour patient will die, you have to tell. I am very sorry to say that time may be very short.
Only, okay.
Only,
Thank
not more than that. So what with the formulation of the diagnosis in the family medicine or the general practice? This is called the triple diagnosis. After the consultation, we have to be able to tell about 3 parameters, 3 dimensions in the diagnosis: biologic, psychological, and social. It is called the problem list, rather in other words. So as a doctor, we have to tell some solution of the problem. For that, in the history taking, there is a social history, mental issue, right? Job problem, family issue, economic issue, many things are there. So all together should come in your consultation. three-dimensional, and our approach will be very holistic approach in our talk. These are the main weapons like general observation plus history taking, physical examination, investigation. And aim of these things, history examination, investigation, all are same. In the history, you may get all the clues. In the examination, you may get all the clues. And in investigation, you may get all the clues. Keeping this in mind, and this is the holistic approach of the patient. And suppose I am now within few minutes, I am telling you about a palpitation case. No need to practice with me now. Just follow me. For example, a common systems involved in the palpitation. If you ask or if you think, maybe cardiovascular disease, maybe thyrotoxicosis, or even the anxiety disorder. If you consider these three systems, so there may be hyperthyroidism, there may be anxiety issue, there may be cardiovascular arrhythmia and other. Okay. And how to proceed in palpitation? It is in the book written. The evaluation of the palpitation. These are the things. Is it regular, irregular? Okay. If it is the regular one, it is a discrete or continuous, and the rate is more than 120 or not. So this is that one. Yes, no, yes, no. A little bit about the palpitation. That is like OPD cats, but it is the nature of the character of the palpitation, the discrete or like that. This is. But what differential diagnosis we can formulate? Suppose this is the anxiety. There may be anemia. Like this is a hematologic disease, patient may have continuous tachycardia will be there. So it is also palpitation. In that manner, we can come to a diagnosis. Okay. But in the book knowledge, if you think that the previous one, if it is atrial fibrillation, because very irregular heartbeat, so we can come to a cause list in our mind that these are the causes: alcohol, chest infection, extra cardiac causes I highlighted here. All are the cardiac disease. So in the past medical history, patient having heart disease are not very important. Okay. In that manner, if you come here, if you are asking the history, the focus history, so we are getting these informations. Please follow. Patient telling that sudden, fast, irregular, persistent palpitation for last 5 days. Only 5 days. So this is the cardiologic symptom, and you are asking about other symptom of cardiology. That is the relevant system. No other symptom. That means patient having only irregular palpitation. But in the general query, you are getting fever. Patient might have some infective disease somewhere, or patient may have even the infective endocarditis, but patient is quite okay from before. Patient didn't have any heart disease, any valvular disease also. So is recently patient having fever. So if you ask about the other systemic information, patient tell you something else. But past history, nothing wrong. Drug history, patient was not taking any medication before this illness. Family history, there is no family history. Ask other symptom of other system. Here is the clue. Though it is the lastly asking, but if you don't have the clue here, you can ask this other system query in the first paragraph also. Suppose you got the fever, but you are not getting the reason, that means the systemic location of the fever. So you can jump from here to there. In this case especially. Now patient telling that, yes, doctor, I have cough for the last 7 days and even a little breathlessness also for last 7 days, and I was taking some medicine in these last 7 days. Now, what may be the cause of this irregular heartbeat? In the social history, nothing wrong. Patient was not alcoholic. So now who can tell that if it is cough, breathlessness, patient having respiratory tract infection, and now patient developing atrial fibrillation. What is the nature of this atrial fibrillation? Who can give an idea? Dr. Amal, please. Yes, Dr. Amal.
You said he took some medication.
Yes, it is only paracetamol and some cough.
Maybe this is related to the medication.
Yes, if it is a cough syrup is more and more. Sometimes cough syrup can produce arrhythmia also. Palpitation. Yes. Any other thing?
Also, Niventolin.
Ventolin for the breathlessness. Yes, if your patient can take more Ventolin, that is salbutamol. Okay, this again drug. Any primary disease can be correlated with the productive cough breathlessness. This is the clue. Who can tell now? Okay. Okay. In the history, you may not be quite confident to tell like this. So we need to go for the examination now. In the examination, you are focusing the cardiology, focusing the respirology. In the cardiology, you found in the general part of the examination in the hand, for thyrotoxicosis, you are not getting anything. Warm, sweaty hand tremor is not there. In the cardiovascular, you are getting regular pulse, no other abnormal finding. But in the respiratory examination, you are getting the features of consolidation in the right chest. So, febrile patient cough, productive consolidation in the right chest, the diagnosis will be pneumonia. So, this is due to atrial fibrillation due to pneumonia. So, it is a temporary atrial fibrillation, paroxysmal atrial fibrillation. So, just I have shown you how a focus history and focus examination could be like this. So, this is a case of palpitation to show you on the. So, today actually I am talking much more, but possibly we may take a few moments to see the video to you. I will request you plus look at the video. It will be of 10 minutes around, and whenever you proceed 1 minute or in between, you can raise your hand so that we can discuss. Not that after 10 minutes we will discuss. In between, I will give you a pause here for you. If you think that in the video performance, you need to talk something, you are telling that, okay, it is not good, it is not right. So please, you raise your hand, we can discuss in between. I think you understood. So I am starting the video for you and follow this video. And may sound may not be actually, may I ask Dr. Zaman, please be connected. Can you tell me the audio is visible, audible to you or not? From the video, please. Dr. Zaman, can you hear?
Yes, sir, I can hear, sir.
Can you hear the voice of the video also? Dr. Zaman?
Over.
Sorry, can you hear the
No,
video?
sir, no, sir, I can't hear any voice of this video.
Maybe the technical problem. Again, follow. Minimum, you can see the body gesture and other also. If you have any comment, you can give the comment to us. If you cannot hear.
My name is Dr. Aram. Can you tell me what brings you here?
Sorry, repeating.
My name is Dr. Aram. Now, can you tell me what brings you here today? Yes, I can see that you're in a lot of pain. I'm sorry, but there are a few things that I need to ask you before we go on today. Can you tell me a little bit about the pain? Where is it? Right, on the right side.
Actually, I have given a pause for you because you are not raising your hand. You need to tell something from the very beginning about the get up and set up of the doctor. Do you have any comment here? Who will tell? Dr. Mahbub. Dr. Mahbub Zaman.
Sir, it's the full sleeve
Full
white
sleeve.
coat here.
White
I
coat
think
is-
it should be, yes, sir.
Yes. And
Yes, sir, I think it should be half sleeve.
okay, then
And she has a wristwatch also.
wristwatch also. About the scarf, do
And
you very feel confident about the scarfing?
sir, I think his scarf is all right.
Yes, relatively all right, but even it will be well organized also, right? It is the culture of the possibly Pakistani doctor, maybe the culture, right? It is true. But again, it will be again suspending. Dr. Uzma, a female colleague, what do you think? Can it be well organized, this scarf?
I think it's a more smaller because it's long on the front and the back.
So it could be better that to fix it a little in the neck around, right? Better.
Yes, little smaller.
It could be better also that. Anyway, so this is the get up setup and you understood. But one thing actually you missed it to tell. So let's move on. You will raise your hand, please, when you need to comment also. I'm proceeding.
Would you like to tell me
Anyway, Dr. Zaman, I think the video, only you are looking the video, not the audio hearing, right?
Yes, sir. Yes, sir.
I'm sorry, I don't know why it is happening. Anyway, so I'm now skipping one for you, so that you can see and comment. Yeah. So the talking is there. Actually, I am not giving you the talk because you cannot hear, but I am telling that before the examination you go.
So that we can do something. Please sit down over
You
here.
just follow how to start the examination and what she is doing.
Are you comfortable sitting? You're fine sitting and lying down? You can just sit for a moment and then. I'm sorry. Just watch it. And just take a back for a moment. And then you look up, please. And down. Please don't ignore your glasses again. Please lie down.
So follow the examination method. She is almost right in your examination, but again there may be some criticism.
Examine your tummy, right? May I please lift your shirt? It's going to come all the way up.
Just permission also exposure.
I'd like to pull down your pant. Okay. Is this the maximum? Yeah.
So is inspecting the abdomen from different angles, right? From side to side and from the foot end.
Now I'd like to listen to it. Just 1 second.
So it's coming to auscultate the abdomen. What is she doing now? So what she is doing, rubbing the hand for what? Dr. Bakar. She was actually rubbing the hand. What is it? Dr. Bakar.
Hello.
Yeah, what is this? She's rubbing the hand. Why?
For auscultation, to need to take the scalpel.
Is it a sanitizer she is using?
No, not use.
No, this is sanitizing her hand. Dr. Hanan, what do you think? Is it sanitizing?
Yes, she said that, but it's too late since I know.
Too late, too late. Actually, sanitizer should be used in the beginning before the history taking. Not only the examination, but you may take sanitizer in between examination also for the second sanitization. But it is usually to be taken in the very first time of your consultation. So not that only auscultation or the palpation before the palpation you are sanitized. So this is rather to say a part of the infection control system. It is erroneous. It is erroneous. Okay. Now proceed a little further. She is looking there. You will examine by yourself.
Press on your tummy, but I'm going to try not to hurt.
Okay, assurance not to hurt you, she is telling. So doing everything. Finally, she will come to the diagnosis. As you are not hearing, no need to see further. So finally, how to conclude it? Assurance and giving the painkiller by the doctor and sending the patient to the emergency treatment facilities. So anyway, the time up. So I'm sorry that as you cannot hear the voice, so I cannot show also the full video. And you can see the video from the Royal College website also, and even we can provide to you also. It is visible in our some link. Maybe in the YouTube link also may be there. Yeah, Dr. Zaman, please, any queries from your side?
So, while checking history, should we sanitize our hands at that time? Or before the taking history?
Yeah, it is the rule. It is the name. It is the custom to sanitize your hand before entering the chamber.
Okay.
It is true for the patient's exam also as well, everywhere. So it is standard procedure. You have to sanitize our hand before, because you know the previously though we are shaking the hand for the COVID situation we are away, but before the COVID situation, good morning, Mr. X. You are shaking the hand, so you are touching the body of the patient, isn't it? So sanitizer always remain outside. Examiner will give the sanitizer. So it will be the custom for you that you will ask sanitizer also. Sir, I need sanitizer. If they don't provide, this is their matter. First time. Second time, no need. Second sanitization not needed because you already sanitized. Dr. Hanan, your query.
Yeah, about the position of CT scope, it is better to put it like as she would about the neck or can.
We are not discussing about abdominal examination right now. We will discuss later in other cases.
No, no, CT scope. She put it above her neck. It is good position or can be put in the pocket or it is okay as I put my CT scope like this in the exam.
Oh, stethoscope actually she took from the wall. Maybe it was suspended other area. So you can keep stethoscope in your hand. But
In
during
my hand.
talk, yeah. But during talk, it is a matter of discussion again. Where the stethoscope will be put, you may take in the shoulder also, over your shoulder. Over your shoulder. But it is better if you can keep your stethoscope in your hand. In your hand.
Okay.
But it's very difficult also because in your hand, how can you keep it well? So if there is any hook system in the wall, suspending hook, so you can keep the stethoscope there. Or finally, for comfortable situation for you, so we can take it over the shoulder. Though it is not good looking, but I think practically we are doing nowadays in the world. Dr. Arif can tell also. Dr. Arif, what do you think? To take the stethoscope over the shoulder, what do you think?
No, sir. It looks odd, and in other exams, it should be in as per their rule. It should be in the hands, and by this way, when the candidate should hold the stethoscope in the hand and talk to the examiner like this.
It is talking to the examiner, but when you talk to the patient at that time, actually it is possible also to keep in the hand. It is also true. It is also.
Yes, sir.
At best in the hand, it is the best tissue. Dr.
Yes.
Amal, your experience and comment here.
Yes, stethoscope, if you put it in the hand and then if you forget it and then the next station will be in a trouble. For that, for me, better to put it in the neck and to put the round one on my bucket.
Yes, it will be second option you are telling. But the best look will be to keep the stethoscope in the hand, not in the shoulder. But even what I observe nowadays in the internet and anywhere that doctors, Dr. Arif, you have seen the many picture also, right? In the pose, doctor given the pose for the picture, and there also they kept the stethoscope over the shoulder. Anyway, if you feel discomfort to keep in the hand, you can take in the shoulder. In my sense, okay. Now, any other issue?
Yes. Excuse me. About shaking hand now in the COVID epidemic. Can we shake in hand with the patient?
Avoid it now in the COVID.
Avoid it now.
Actually, examiner also will tell you, don't shake the hand. Right? They are very serious about this. Any more queries? Please, Dr. Arif.
Thank you, sir. Sir, do we have to wear PPE during the examination?
It is a matter of understanding what they are thinking about. If COVID situation is still persisting, so
yes, sir.
Suppose in the general physician examination, there will be no patient. And
okay. If
I am telling you, they may organize the station in a manner that you may not need to touch the patient at all even. What they will do, what we are doing, what we will be doing now with you now in the course. Okay? I like to examine the test. I am going to examine your test, Mr. X. Mr. X will tell you that what you like to see. I will auscultate or hear your chest in the apex or like that. This is normal. In the back, this is normal. They will tell the finding. It may be also true if COVID situation is there, right?
Yes, sir.
Because
Even in case of clinical cases, sir, also.
that I'm telling all the cases are clinical case, suppose 14 station. So there may not
Oh,
be
I see.
examination,
Yes,
maybe
sir.
there are 4 5 cases that examination not needed. But in other stations, they will tell you that examination needed. But when you enter the station, you may find that all are instructed.
Okay.
Your approach is important. What do you like to see? What do you like to see? Maybe one thing. But PPE nowadays, you know, Dr. Arif, that in the patient's examination, they are
Yes, sir.
allowing the PPE doctor, they are examining the patient. But MRCGP, actually, I don't know that much they will
Yes, sir.
do this thing or not. But as MRCGP,
Okay, sir.
real patient is not there, they will produce some pictures, some finding cards, or examiner will tell you these are the findings. Maybe that attitude they will take in future, in the recent
Okay,
exam,
sir.
rather to say in the recent exam within few months. Okay, any query? Dr.
Yes,
Bakar
sir.
or anyone? Any query? No more, please. So we can proceed now. Actually, we are passing already the break time and we have few minutes more in our hand. I will tell you some extraordinary things also. You know it, but from my side, I like to give you some hints, some other, it is extraordinary, breaking bad news and other issues also. So if you don't have query, I think we may proceed. Dr. Uzma, what do you think? Can we proceed? Or you become tired?
Yes, doctor. Actually, I want to ask some patient is bring the report.
Yeah.
For asking doctor what the report say, that what's the problem for me. I would ask that some of the doctor told that when you see the report, just you can focus history like 4 5 question, and then you can start the eyes, and then you can start the yani management and consultation. Not too much asking question. Like
Fact.
so, this is like
This is
confusion
true.
point actually
No,
in my
no.
mind.
What you are telling, this is the fact. This is the fact. Your main job in station is the investigation analysis, not the history taking. Not the history taking. But why we are taking the history? Just to be confident enough that the investigation report is compatible with the patient presentation or not. So only 2 3 questions enough. Second, for the management purpose, idea, concern, expectation important, right? What patient is thinking, it is not important for the investigation. Suppose the investigation is very diagnostic of diabetes. Clear?
Yes.
So what patient is thinking is important for the management purpose only, not for the diagnostic purpose. Okay. But if you tell the patient, okay, Mr. X, you have blood sugar high. So idea of the patient is not important no more. Before confirmation of the diagnosis, patient may think that, okay, it may be that disease, those disease. But the report is evident in front of you. But so what is the value of idea concern? Concern may be there, but about the idea, not important. For that, for the history taking, just ask about few symptoms and what you are thinking. If it is a breaking bad news by the report, you can ask that what you are thinking the report could be. You can ask in that manner. Finally, some social history. That's why he is living about the diagnosis after management issue. How will you guide your patient? For that, you can take earlier in the social history. But another strategy also possible. Whenever you get the report, you can see, okay, before telling the diagnostic information, you ask about the history. Okay, you are confident that the report result and the diagnosis from the history, finding, or previous information, you are confident enough. So after telling the diagnosis, regarding the management, you can take the social history after telling the diagnosis or after telling the investigation also. Suppose a microcytic hypochromic anemia, the report is telling hemoglobin is low. It doesn't mean that you have to ask about melena, other, and the family history of the bowel carcinoma or not. You tell the report first. Patient first attention is to get the information from the report, not that you will take the history. Clear, Dr. Uzma? This is the priority. But
Yes,
after the
yes.
diagnosis is over, then you can talk a little more. But what I observed in the practice session that doctors are more busy about the history taking. They are spending 6-7 minutes. So report description is pending. So you are not having enough time. Patient will ask you about the report 5 or 6 questions. So what you will give the answer? So what Dr. Uzma said, this is true. Rather, I am very stringent also that talk very less, 2 or 3 minutes, not more than that. Clear now? And come to the middle part of the consultation, more on the investigation, then last part of the management plan. This is my suggestion for you. Any more query, please? I think no more. Thank you very much. So it will be my opportunity to end the session after a few minutes to tell you something more. A very common was actually it was rather to say in my time before. Nowadays I heard that this station is not very commonly appearing in the exam. Maybe some technical reason is there. But in our real life situation as a doctor, we are facing this problem. So we must know it. What we actually organize is angry patient or angry relative management. These are the headlines. These are the headlines. And I'm telling about this. This word is very self-explanatory. And I request you or guide you or direct you to observe or view a video given in the YouTube. There is a YouTube link also for you. You can see there managing angry patients. It may not be a perfect video, but you can just observe some principles of there we discussed in one other session, maybe in the very introductory day, a few months before. So this is one of the angry patient issue. These are the headlines we have to follow in the angry patient. And if you come to another case, oh sorry, about the anger, there is some good response in the social media. I like to share with pleasure. They are my students. They become new doctors. So regarding the anger management, one doctor replied that don't get revenge with anger, but with skill. So this is one response and comment. And another colleague, their friend, they are responding each other. This doctor telling, nobody actually take revenge, rather leave the thing. So it may be good attitude also. The anger will not be combated by the anger. This is the fact. So it needs skill development to do this. Okay. But when doctor will be angry, what can you do? Dr. Uzma, what can you do? Like that, you become angry. Doctor, what is the of minimizing?
Yes, doctor.
If the doctor is angry, should doctor do it? Or did you do it by yourself anytime? What do you think?
No, we are not angry, but
You're not angry? You've never been angry.
angry, doctor.
Dr. Bakar, if you become angry, what you will do? You will shout to the patient. Huh? Dr. Bakar?
If I am angry, they need to fire.
They need to fire. Dr. Bakar, what will be your attitude if you become angry? Dr. Bakar? Sorry, we cannot hear you well, Dr. Bakar, today. I don't know. I have given the signal to you to open your mind.
Try to be calm.
So this may be way out there, but don't break the mirror also. It may be injurious to you. Okay?
Yes.
Don't
Try to be calm.
So this is the angry management issue, and now very important issue in the examination. All the time, one student will be breaking bad news. So this slide showing you that after telling the breaking the bad news to the patient, you have to observe the patient's reaction. There may be different types of reaction, or it may be a sequential one also. First the denial, then the anger, guilt feeling. Patient may be depressed. Finally, patient accept the diagnosis and patient will be hopeful. And you are the doctor to provide the hope to the patient. So these are 5-6 things actually we have to remember, and just mnemonic to help you, Dagada like that, that if anything may happen in the patient. Even with the depression, patient might be muted also. Patient cannot talk also. So it will be your skill in the breaking bad news station that you have to be silent for a few seconds. It is acting only. It is called the golden silence. You have to do it. In the practice time, we will show how to do it. And these are the headlines to follow, especially in the breaking bad news. Identification is very important, not only by name. So may I request Dr. Arif how to actually to be confident about the identification of the patient, especially in the breaking bad news? Dr. Arif.
Sir, can you please repeat the question, sir, again?
In the breaking bad news station, identification should be very confident. So how to make a
Yes, sir.
confident identification? How to do
Okay,
it?
sir. The identification for this, we need two things. The name and age of the patient is very, very important.
Can you
And
practice
in
with
case of,
me? Can you practice with
yes,
me?
yes,
Few
sir.
seconds. Yes, is it
Good
Mr. X?
evening. Good
Yes,
evening.
Mr. X.
Good
Yes.
evening, Mr. X.
Good
I'm
evening.
Dr. Ali, one of the doctors in this clinic today. Am I talking to Mr. X, who is
Yeah.
72 years of age?
Yeah, doctor.
Okay.
And any more?
Um,
Is the test done 2 days
uh,
before? Is the test done 2 days before? It is also a fact, right?
yes. Yes, sir. Yes, sir.
So, yeah. So, my all of beloved colleagues, today you observe Dr. Arif asked two questions together. Better to ask one by one. Hello, Mr. X. First identification is there. Is your age 72 years? Yes, doctor. Second cross check is there. Is the test done 2 days before? Yes, doctor. Third cross check is there. So how many need? Three enough? 2 to 3. So it is
Yes,
strengthened
sir.
identification.
Yes.
It is especially needed in breaking bad news. So that you should not tell any
Okay.
bad news to wrong people. Don't give any chance that
Yes, sir.
you are telling the bad news to the wrong people. So these are the very important thing. These are the headlines we will show in our practice session. And again, Dr. Uzma, you told about the history taking and other. Better not to be busy with the history taking many things. Your idea is to give only breaking bad news, not the diagnostic approach. It is very clear that in the breaking bad news, diagnosis almost completed. Tissue diagnosis will be there for the malignancy. So why you are talking about the history examination and other, right? Only one in a manner that how do you feel today? And what was your problem? Patient, I have cough or colorectal bleeding like that. Okay, thank you. So do you have any idea about the report could be? In that manner, you have to proceed. Don't take more history in this case. Even the social history, other also. The main agenda of the breaking bad news is to give the bad news and to respond to the reaction of the patient. This is the main issue. Finally, the talking about the management plan again, especially in the management plan, you need to second permission gently that can we continue our talk, please, in that manner. That means I told you one thing is that golden pause, silence. After the silence, you will tell, can we continue our talk? Not that, okay, don't worry, we will have very good treatment and other. Let the patient to tell you, okay, doctor, can you tell me what can I do now? So in that manner, you will talk. And you are following me also that I'm talking to you in a very slow speed. This will be the speed in breaking bad news. Your speed will be low. This station is the station of performance, not the talking, remember. Station of performance, not the talking. So talking will be very less, very less. So we hope that we will make you actually perfect, inshallah, in our coming sessions, in our practice session about this breaking bad news. So this is very important issue we talked about. These are some ethical principles. I am requesting you, we can provide you PDF also, possibly we have provided to you. These are the 4 talks: autonomy, beneficence, non-maleficence, and the justice. In the MRCGP especially, more attention I observed that in the consent and confidentiality, the ethical issue, consent and confidentiality. But we should not forget this thing, autonomy also, beneficence, non-maleficence, and the justice. This is the basic ethical principles of a patient. And in the confidentiality, when to break the confidentiality. So make a snapshot, please, by yourself. In this situation, we have to break the confidentiality. It means that for the benefit of other people of the community, of the nation, of even the spouse, husband-wife issue also, we have to break the confidentiality. This is also rule. But in general, as a basic principle, confidentiality should be maintained for the patient. Okay, these are some examples given to you. And these are some other information regarding the confidentiality. Please make a snapshot. And we're coming to the legal issue. It may be the last slide possibly to you. Regarding the DVLA, so diabetes, heart disease, epilepsy, especially in the MRCGP, diabetes and epilepsy is more important. Diabetes and epilepsy. Even then, we need to know about the heart attack patient. Is a driver there, type 1, type 2. We have to discuss this thing, in the meantime, what is DVLA and when DVLA should be informed. So these are summarized information for you. We can give you the PDF also if you don't have. This is a diabetes issue in the driving. 3 months always, minimum 3 months, patient should be off from the driving if patient is on insulin. This is the basic thing. This is again the other diseases in a summarized tabulated form for you. Epilepsy, stroke, acute coronary syndrome, ICD implanted patient, hypertrophic obstructive cardiomyopathy. You know that this is the Harbinger for the arrhythmic condition. And finally, the diabetes. So 4 or 5 diseases almost throughout the world in any examination, not only the MRCGP, rather even the PACES and other also, these 4 or 5 conditions should be in the mind. Should be in the mind. So this is driving the legal issue. And the legal issue is over. And now come to the final conclusion. This is the blueprint for the OSCE, acute, chronic, psychosocial, and the prevention lifestyle issues cases will be selected according to the systems like that. And we divide our course also, or in the exam also, that chronic, acute disease, counseling, ethical, legal issue, and the breaking bad news. A little modified approach for you for our practice purpose. And we make a checklist like that for our practice. Every time we will show you, make a snapshot also. In the consultation, our idea is to diagnose, to identify etiology, complication, comorbidity. What will be the investigation plan in your consultation? Management issues are there. Red flags, idea concern, hidden agenda, and ethical issues. More or less, this will be very important in your consultation. So we will show you. And in your practice, our suggestion is that please make a handwriting the checklist by yourself after each practice session by yourself. You may share with us in the group also so that we can comment there. So one doctor has done nicely in our previous courses. The main agenda according to the box shown to you before. What is the investigation plan, management, red flag, hidden agenda, maybe there. You can create your hidden agenda also. No problem. It will actually increase your creativity if you do this. Though it will take time, but it will be very asset for your future life also. We have done it. Myself, I can remember we have done it. These are the common mistakes done by the candidates in the OSCE. This is the expert person told before. So you don't do it. So we will try our best to guide you not to do it. Not to do it. And our course motto will be actually to guide you how to fish, not how to eat cooked fish. Because if you know how to fish, you can eat the fish all the time. This will be our course motto. Try to remember it. And this is the end of our actually discussion today. So a long time, but not long time. This is our targeted time. Actually, we come across around 2 hours, 30 minutes time. And in the introductory class, I tried my best to inform you many things. You know many of these things. And we have provided many text and literature to you. If you need, we can provide more to you also. I think we can give some PDF and other in the group. If you don't have any material, you can pick up from there. And within today, within tomorrow, you can go through, especially the article written by myself is the how to improve clinical consulting skill. You can create a philosophy of the consultation, then your performance will be the best. And these actually taken the information taken from Royal College of General Practitioners. These 23 principles of consulting skill. So from my side, thank you very much. The mic is open for you, everyone. If you have any query, we can make 2 minutes, anything about for the next coming days. Thank you very much. Please, anyone, Dr. Amal, any query from your side? I have given the mic.
No,
to
thank you.
everyone. Thank you very much. Okay, Dr. Zaman, everyone, please, you share your comment, please. If anything in your mind to ask me.
It's okay till now, sir. I think it's okay
It's okay for you today's discussion. Dr.
till
Bakar,
now.
Dr. Bakar,
Yes, sir.
Dr. Bakar, please. Hello.
Thank you. No question.
No questions. Right. Fine. Dr. Hanan, any questions?
Hello.
Dr. Hanan. Sorry.
Thank you for the question, but for the start, it can be 7:15
Sorry.
for prayer time.
Oh,
For
you can.
starting the lecture.
Oh, for the prayer time. Yes, important issue. We
Seven.
can decide later. Okay. Any other signatory? Any comment for the course?
Thank you.
Dr. Arif.
Sir, it's beautifully designed. And regarding the timing, 8:30 can be, if possible, 8:30 sometimes beneficial.
No, Dr. Arif, actually, everybody may have some limitations also. And
Because they have
actually
some
our
prayer time today.
I understand. I understand.
Yes, sir.
We can give an suggestion for the prayer time. And Dr. Uzma, please, any comment?
Yes, sir.
Dr. Uzma, any comment from you?
No, sir, time is okay. Because only I told you before there is some Eid breaks, like
Oh, that
you
we'll
need to
discuss.
ask.
Yeah, doctor. In that time, if you come across this time we have put, we can modify on that time. You told before, right? So thank you very much.
Time is fine.
Now regarding the prayer
Thank
time
you,
and other issue. So before that, we like to thank everyone for our. Actually, you don't have any issue regarding our talking today.